Great, thank you, Lauren. So again, I'm Jocelyn James. I attend an adult medicine clinic at Harborview, and I do primary care and addiction medicine. And I am going to start off, so I'll go through also just the plan for the day. Jared, Jamie, and I don't have any disclosures to report. Our session plan for today, so we're taking on a kind of a potpourri of some substance use topics. And we'll start out actually with talking about overdose and other harms to people who use drugs during the COVID pandemic, and also talk about harm reduction. Take a quick break and then turn to managing pain in people with opioid use disorder. Take another quick break and then do some case discussions involving buprenorphine and fairly common challenges that come up during buprenorphine treatment. And for that, we'll divide into small groups. So these are the main learning objectives that we set out for today. So number one, to understand major trends in overdose death in the United States. To increase our comfort speaking to patients about key harm reduction strategies, to demonstrate 3 strategies for managing chronic pain in patients who have opioid use disorder, to manage medications for opioid use disorder in patients experiencing acute pain, and then to increase our comfort discussing with patients their challenges during buprenorphine treatment. Okay, so I'll turn now to the first talk. This will be, we're going to go through some slides. Jamie and I'll start out and then turn it over to Jamie. And I do want to just acknowledge that talking about overdose, talking about substance use alone can be kind of a heavy topic, and talking about overdose, especially during COVID, can be as well. And I'm going to be showing a lot of numbers here in my part too. So I think I just want to acknowledge the people behind those numbers. I'm sure some of you have had patients suffer an overdose and possibly a fatal overdose. I know that I have patients in mind myself, and mostly what we will be focusing on today is some of the greater trends. So for this talk, the key objectives we want to take away are just understanding the key trends in overdose death in the United States, identifying 3 reasons that people who use drugs are at increased risk of harm during the COVID pandemic, and then again, increase our comfort counseling patients about harm reduction as one area that we can focus on to try to help improve outcomes for our patients and partner well with our patients. I wanted to start out with this question. We're not actually going to make it a poll, but if you can just take a look and think about what you think is the most accurate answer here. We'll come back to it later. So which of the following best describes your understanding of overdose deaths in the US during the COVID pandemic? A, overdose deaths were finally on the decline prior to the pandemic, but have increased during it. B, the pandemic does not seem to have affected rates of overdose death. C, overdose deaths began increasing prior to the pandemic and have been accelerating during it. And D, heroin appears to be the main driver behind increasing overdose deaths. So I'll let you think about that just for a minute. Okay, and then we'll go into this. So I wanted to start by just providing a snapshot of what overdose, of the status of overdose death in the United States pre the COVID pandemic, and then look at what happens during it. I'll also go through some both direct and indirect harms that people who use drugs have experienced during COVID-19. And then again, we'll talk about harm reduction. So here's a snapshot of drug overdose, of the drug overdose epidemic prior to COVID. This is, so first in 2019 in the United States, there were just under 71,000 overdose deaths. And of those, opioids accounted for up to 80% of those deaths. A CDC study that involved, it was not really completely representative geographically, and I will say kind of underrepresented the West Coast, but a CDC study that involved 24 states and the District of Columbia and looked at overdose death between January and June of 2019 found that 3 of 4 of those that were related to opioids involved fentanyl. So we know that opioids account for the vast majority of overdose death in the United States, and then it looked like 75% of those now are involving fentanyl. And I put fentanyl in quotes there just to prompt myself to remind you that when I'm going to use the term fentanyl, but I mean illicitly manufactured fentanyl, including fentanyl analogs. And this 3 out of 4 is an increase. So previously it was more like 2 out of 3 or 60, closer to 60%. And then it's also important to know it's not all about opioids. Rates of death from stimulants, both cocaine and methamphetamine, have increased dramatically in the last 5 years. We'll look a little bit closer at that. So this is a graph to just show us what we're talking about. Overdose deaths have been increasing in the United States. There was a downturn of about 4.6% in 2018, and people maybe got a little bit hopeful that these trends were changing, but that bumped up again in 2019. So you can see that the most recent data shows an ongoing increase in overdose death rates. And then we'll look at this a little bit more closely. So the chart on the graph on the top here, this is age-adjusted rates of overdose death involving opioid. So we're looking only here at opioid-related overdose deaths, and this data has recently been updated through 2019. And you can see that that top category in blue is synthetic opioids other than methadone, by which they mean illicitly manufactured fentanyl. So this is deaths related to fentanyl, and you can see that how scary that trend is. Fentanyl is considered, it appears to be the third wave of the opioid epidemic, opioid overdose epidemic, where initially that epidemic was driven by a rise in deaths related to prescription opioids, and then in about 2010 from heroin, and then more recently fentanyl. And it's that last one that's really continued to drive the increase. And then on the bottom, you can see age-adjusted rates of overdose death involving stimulants. And of note, the rate of overdose death from methamphetamine specifically has increased on average 29% per year since 2012. And you can see that the death rate from methamphetamine, that psychostimulant category, has actually just taken over the death rate from cocaine. And then there are other disparities by race, by age. One example is looking at just death rates related to cocaine. So the top figure is rates of death of drug overdose from cocaine by race and ethnicity. And of course, there's probably some misclassification here, but rates of death from overdose due to cocaine are roughly appear to be two times that in Black Americans compared to white Americans. And then age is also an important factor, and these trends are changing and do vary a little bit by race as well. But on the bottom there, you can see that this the green line is age 35 to 44. And if we look at rates of overdose death by age, it's that group that really appears to be suffering the greatest increases right now in overdose deaths. I think it's also important to highlight some differences by region. So because things are different on the West Coast. And here's an example. So this is on the top, it's we're looking at deaths from overdose related to methamphetamine on the top, and then from cocaine on the bottom. And looking at the top figure, deaths related to methamphetamine, what they're showing us here is how many of those deaths also involved opioids. And you can see that overall in the United States, more than half did involve opioids, but on the West Coast, actually a minority, a sizable minority, but a minority also involved opioids. So most people who are dying from methamphetamine overdose on the West Coast are dying simply from methamphetamine, plus or minus other substances, but not with opioids on board. And that's a little bit different for cocaine. There's still geographic variability. So in the United States overall, 75% of people who die from cocaine-related overdose have opioids on board, but it's a lot lower, 63% on the West Coast. So things are a little different in our region. Okay, I want to turn now to what we know about what has been happening during the COVID pandemic. And first I'll focus on direct impacts of the COVID pandemic on people who use drugs. So first question really is, are people who use drugs more vulnerable to COVID infection? And we can look at both, are they more likely to get infected? And then are they more likely to suffer severe consequences? And in both counts, it's pretty clear that people who use drugs are indeed more vulnerable. So regarding likelihood of infection, just the act of procuring, getting a hold of drugs, and also the way people use drugs may lead to decreased physical distancing and decreased hygiene. And some examples of this are most people still obtain their drugs not over the internet, but through face-to-face contact, so through in-person contact. People often leave their homes, for instance, to go smoke, or going in and out, and often kind of grouping together to some extent. And then a lot of drug use does involve hand-to-mouth actions, which can potentially become more important when you're talking about infection and transmission risk. But also, as you know well, people who use drugs are really strongly overrepresented in a lot of congregant settings, represent more than 50% of incarcerated populations. And then thinking about opioid treatment programs, of course, all those people are using or have used drugs. There's very high rates of homelessness and food insecurity. And so people who use drugs are more likely to find themselves in congregant settings. So turning to consequences of infection, there are also a number of reasons that people who use drugs are more impacted by, or more likely to be more impacted by COVID infection. Prolonged substance use is affected with a high prevalence of heart and lung disease. Substance use itself can impair the immune response. And then there's this whole host of broader psychosocial overlap here that can affect people who use drugs. So they often suffer from decreased access to care, decreased quality of care, stigma and discrimination play a role. They are likely to have less access to technology, high mental health burden, and a lot of competing basic needs. And so getting COVID infection in that setting may well lead to less prompt treatment and lower quality of treatment, different treatment seeking behavior. There is some more objective data looking at this. So this is a retrospective but very large case control study looking at more than 73 million patients, and this is based on electronic medical record data. And basically these authors wanted to look at whether having substance use disorder was associated with a higher risk of getting infected with COVID, and then also with higher risk of complications. So both of those questions that we just were talking about. And they found that of a population of 12,000 of people who in this database who had had COVID infection documented, it looked like people with substance use disorder were more than 8 times as likely to have had COVID. And then those with COVID and a substance use disorder were both more likely to be hospitalized and more likely to die. And so if you look at the figure here, the top panel is death rates among patients, and the bottom panel is hospitalization. So if you look at death rates, on the left, you see just having COVID-19 infection, and then you can compare that to what happens when you add in substance use disorder. And I'm sorry the writing is so small there, but the middle column is COVID-19 plus all substance use disorder, and the right column is recent substance use disorder. And you can see there aren't really major differences between those. So we're really comparing that left side to the other two, and the rates of both hospitalization and death appear to be higher. The other thing that's pretty striking about this figure is the colors are showing you differences by race. So African American compared to Caucasian patients, African American in blue, and African Americans with COVID and substance disorder are more likely to both be hospitalized and to die when they have COVID, according to this data. So those were some of the more direct impacts. I did want to comment on some of the less direct impacts, but also very important impacts on people who use drugs. I think we've probably all seen a lot of examples of this. So one is that people who use drugs may be disproportionately impacted by having their care systems disrupted, their routines disrupted, suffering from the loss of in-person social support, which can be so important for this population. Potentially having access to medications for opioid use disorder reduced, which when we know that medications for opioid use disorder are one of the most life-saving interventions for people with OUD. Also having decreased access to other psychosocial addiction treatment and mental health care. And then thinking about the COVID infection in incarcerated settings and the push toward early release, which probably on the whole has hopefully helped people be safer. But if people are getting released early without systems in place to get patients, again, more than 50% of whom have substance disorders, to get patients linked to OUD care, for instance, to get them on medications for opioid use disorder, then they could be at high risk of harm. We know that overdose is particularly high after being released from incarceration. People have also suffered from reduced access to harm reduction, and Jamie will show you some data later on this from a Syringe exchange program survey, a national survey. But it's clear that even by March and April of 2020, Syringe exchange programs had cut back on their services. About a quarter had actually closed at least one location. HIV and hepatitis C testing essentially got just widely cut because of the in-person requirement. And then, with decreased access, also all the services that come with the syringe exchange programs, like referrals to treatment and other harm reduction. And then people who use drugs may change their use patterns because of COVID infection. They may be more likely to use alone, which is a risk factor for overdose. And they also are vulnerable to changes in the drug supply and unpredictability in the drug supply. And so there's evidence that there's more impurities in the drugs. We have reason to think that injection drug use goes up in the setting of economic downturn. And then with potentially disruptions in access, people could be at risk of harm from losing tolerance and then being more vulnerable to overdose. Here are a few more examples. So I think there's very interesting data around people who use drugs and their vulnerability to stress. Substance use disorder itself is associated with increased vulnerability to stress, and stress predicts recurrence of substance use in people with substance use disorder. I've personally heard this story so many times of people who are doing really well in their recovery, and then their mom dies or their partner dies, or some major life event happens and they return to use. And then mental illness, concurrent mental illness is, of course, very high among people who use drugs. And there are concerns that there would be increased suicidal or even parasuicidal risk taking in this population, just with all the stressors, all the multi-dimensional stressors from COVID pandemic and the loneliness and isolation. I think we all see this probably in a lot of our patients, but in particular, people who with substance use disorder are really likely to be impacted by higher rates of food insecurity, housing insecurity, loss of employment, and are likely to, likely that those consequences are piling on and affecting them in particular. And there is some data that shows that, for instance, counties that have higher rates of unemployment have increased risk of overdose deaths. So there's some more historical data that suggests we have reason to be worried that when people are losing their jobs, that overdoses would go up. And finally, just a comment on the over the long term, of course, the research and building programs is so important, and there are concerns that will slow down because of COVID. Here's just do a quick time check. I think I'll actually skip this, but I'll just say for the sake of time, because I want to make sure I turn over to Jamie in time. But this is a really interesting report if you're interested in how the drug supply appears to be affected by the COVID pandemic. It's from the United Nations Office on Drugs and Crime. And the one a couple big takeaways I would just make before moving on are that in general, when there's an economic downturn or a shortage of a drug, we see increased use of injection drugs, and also an increase in drug use overall. I just wanted to include a quick comment on this. I think telehealth has been, in many ways, a real, we've seen it be used effectively during the pandemic, and it can be used for initiating buprenorphine, which is fantastic, and even for monitoring patients on methadone. But people with substance use disorder also, there have been a lot of concerns, and I feel like I've seen this personally, that because they have decreased access to technology and maybe more other needs for social services, for behavioral health, et cetera, maybe really not adequately served through telemedicine. All right, so now turning to what we do know. So there are a lot of concerns about both indirect and direct harms to people who use drugs during the COVID pandemic. And I'll turn now just to show you some numbers on what we've seen as far as actual drug use and overdose death. So this is a CDC survey from last summer, which basically just showed that a high number of a high percentage of United States adults reported initiating or increasing substance use in those early months of the pandemic. So 13% of US adults reported that, and 40% reported struggling with either mental health or substance use, remarkably high numbers. There were very early concerns. There were a lot of really great articles in the press, based on talking with people, with providers, that raised concerns about increasing rates of overdose. And there was early data that this was true. This is from a program that monitors both fatal and non-fatal overdoses through a variety of means and gets more real input from a variety of sources, and so has more real-time data. And just by May of 2020 found that it looked like compared to the prior May, for every 10 suspected overdoses that were reported that prior May, there were 14 in May of 2020. And also that the month-over-month increases appeared to be higher than they had ever been. And then in December, the CDC came out with an alert, essentially, that confirmed what a lot of people had been suspecting, which is that there had been a substantial increase in drug overdose death in the United States. And they found that in the year that ended in May of 2020, it was the highest ever recorded. They've updated this a few times, and by last month, the available data shows that we expect the provisional data suggests over 88,000 deaths from overdose in the year that ended in August 2020, which is a huge increase. Remember, 2019, it was just under 71,000 deaths. So a really dramatic increase in overdose death has been confirmed, unfortunately. And this chart is looking at the specific drug classes that contribute to that. So this chart is looking at United States overall, and for all drug classes, and then looking at the number of deaths. And that black line is all opioids. So you can see that opioids continue to drive the vast majority of overdose death. And then you can see that brown line is basically fentanyl. So that's being driven, again, largely by fentanyl. Down there in gray is methamphetamine, much lower nationwide, but again, it's crossed the line of cocaine and continues to increase. So those are very large percentage increases. And then I mentioned that there were differences geographically with the West Coast compared to the rest of the country. And it's important to be aware that there are some really rapid changes and important changes that we're experiencing here on the West Coast. So methamphetamine is playing a particularly large role. On this first figure, this is looking at Washington State rather than the nation. And you can see those same color-coded lines there. So opioids account for the vast majority of deaths, but below that is the gray line representing methamphetamine-related overdose deaths. And then you can see that although in Washington, fentanyl-related deaths, the brown line, are less. They're rising very quickly. And that's an example of that on the bottom. All right, I need to turn this over to Jamie, but I'll just say that this chart is basically showing you that indeed, although overdoses were increasing already, largely driven by fentanyl prior to COVID, that increase, the month-over-month increase, is accelerated in the early months of the pandemic, and really suggests that there has been an acceleration of overdose-related death during COVID-19. So if we go back to this question, I would argue that overdose deaths began increasing prior to the pandemic and have been accelerating during it. If we have time later, we can reflect on, or maybe at home you can reflect on, or later, what do I do with all these numbers and with these trends? And is there, what can I do with my patients? And I just threw down a few ideas. I'm sorry we don't have time to discuss them as a group. So conclusions: people who use drugs during the COVID pandemic are increasingly involved in a syndemic that also involves basic needs, competing priorities, inequity, and stigma. COVID, fentanyl, and meth are causing a perfect storm, leading to an acceleration of overdose death. All right, and I'm going to turn it over to you, Jamie. So let me try to give you remote control. Great. Let me know if it doesn't work, and I can.
Thank you so much. Let me see if this. I don't think it's letting me advance, but so I don't know if you want to, if you could just click through, or I can share my screen. I don't know what's. Oh, you're on mute, Justin. Would you mind? Would you mind if I just asked you to advance the slides?
Sure, no problem.
All right. Hi, everybody. I'm Jamie Darnton. I work with Jocelyn at Adult Medicine Clinic, doing primary care and addiction medicine. Thank you so much, Justin. That was really a really great overview of this collision of the overdose epidemic and the COVID crisis, and good insight into how it's affecting our patients who use drugs. I'd like to spend a little time talking about some ways we can talk with patients in clinical encounters to mitigate hopefully mitigate some of those risks. So I'd like to talk about spend a little time talking about the notion of harm reduction from a 40,000-foot view, the kind of philosophy and rationale behind it, and then get into specifically a discussion on naloxone, on safer use counseling, and on referral to syringe service programs. So nothing groundbreaking, you know, all tried and true, but I think bears you know, a deeper dive into how these strategies might help your patients in the face of these increased risks. We won't be talking much in this next few minutes about treatment, in particular agonist treatment with buprenorphine or methadone, which of course dramatically reduces risks of overdose mortality and all-cause mortality, upwards of 50% in most meta-analyses for those two medications, because we'll be talking about a lot of details and nuances of that later on this morning in future presentations. So if you can click ahead. Great. So harm reduction is a grassroots and user-driven set of compassionate and pragmatic approaches to reducing substance-related harm and improving quality of life without requiring abstinence or use reduction. That's in its application towards substance use disorders. Of course, harm reduction as a concept is familiar to us in medicine. It really trying to reduce the risks of behaviors without necessarily altering the behavior itself. David Purchase of the North American Syringe Exchange Network describes it as more of an attitude than a fixed set of rules or approaches. And I kind of like that approach, and we'll kind of look at what that attitude entails. And of course, there's discussions of harm reduction at all all levels, public health initiatives, legal advocacy, but we're really going to focus today on the level of the individual patient care and counseling your patients. Next slide, please. So the Harm Reduction Coalition lays out 8 principles of harm reduction. I want to just review the first 4 because I think this is just a really great description of the philosophy that underlies this approach. Harm reduction accepts that for better or worse, drug use is part of our world and chooses to work to minimize its harmful effects rather than to simply ignore or condemn them. Understands drug use as a complex, multifaceted phenomenon that encompasses a range of behaviors from severe use to total abstinence, and some ways of using are safer than others. They establishes quality of life and well-being, not necessarily cessation of drug use, as the criteria for successful interventions, both on an individual level and policy interventions, and calls for non-judgmental and non-coercive provision of services to people who use drugs in their communities. Oh, thank you. I won't spend too much time on this, but you know, the harm reduction in the sense of disease prevention, provision of materials, and dedicated harm reduction centers really kind of came to being in the Netherlands, no surprise, in the early 80s, driven by the HIV epidemic. And the Rotterdam Junkie Bund, which was a collective of activist drug users, were really instrumental in as stakeholders in working with the Dutch government to enact some of these harm reductionist policies, and the government established the first needle exchange program in that country in 1984. In our since then, in our country, there's been a lot of back and forth, and a lot of harm reduction services were provided illicitly. And there's still a patchwork of different laws regulating what you can and can't do in different jurisdictions. The first legal syringe service program in this country was actually in Tacoma, which is pretty interesting, in 1988. So Rationale, you know, traditional treatment approaches for substance use disorders which focus on abstinence do not work for many and do not engage most. We're still thinking about 1/5 of people with opioid use disorders have access to evidence-based medication treatments. Abstinence and use reduction can be a way to reduce harm, but they're only one way. And in the face of these increased risks of serious harms to people who use drugs, in the face of this syndemic that Jocelyn described, you know, this really underscores the need to focus on drug-related harms. Next slide, please. So looking at a kind of general approach here, I like this graphic from the UW Center for Harm Reduction Research and Treatment. Harm reduction treatment is actually an evidence-based counseling modality. You know, behavioral health counselors, substance use disorder professionals, and can undergo training in this. But I think the kind of philosophy underlying it is really the important thing that you can take to clinical encounters in the medical context. Really bringing to bear compassion, pragmatism, and advocacy to these encounters. You want to elicit the patient's harm reduction goals. Do they want to repair their relationship with family? Do they want to get a job back? Do they want to stay out of the hospital? Or do they want to reduce or stop their substance use? What are they looking to do to improve their quality of life and well-being? Establish some sort of feedback or tracking mechanism that's patient-driven to measure progress, and then discuss safer use strategies and relative risks of various use strategies. And that's really the part we'll focus on a little bit here. And all of this in combination with evidence-based medication treatment. Next slide, please. So we're going to talk a little bit about naloxone. So naloxone distribution started 20 years ago now as a fringe harm reduction effort. This group in Chicago drove around in a van distributing injectable Narcan. It was very controversial at the time. And fast forward 20 years, our prior Surgeon General was advocating for every resident in the United States to carry naloxone to help reduce overdose deaths. So it's really come into the mainstream, as you guys know. Next, there's a ton of research over the last 10 years showing that targeted dispensing and education around overdose is feasible. That these trainings increase knowledge and skills around overdose reversal in the community. That dispensing naloxone does not lead to an increase in drug use. Rather, it does lead to an increase in folks seeking treatment for substance use disorder. Targeted dispensing leads to reduction in overdose in communities, and it's cost effective. Next slide, please. Health and Human Services has recommended the prescribing or dispensing of naloxone in different scenarios. One is for anyone for whom you prescribe an opioid who's at increased risk of overdose, but also anyone using opioids illicitly. Category 2 here is one that I don't think is penetrated fully, but I think is really underlined by some of the data that Jocelyn presented, that you really do want to discuss keeping on the naloxone for people who use stimulants, particularly cocaine, as we saw, as you know, the supposition is a lot of those cocaine-related deaths are driven by synthetic opioids that are admixed in there. Methamphetamine, we've seen it too, though, as Jocelyn presented, the majority of methamphetamine overdoses do not include opioids. So they're a function of the methamphetamine itself and harms from the methamphetamine itself. You want to offer it to people who are in treatment for opioid use disorder. And I think that can sometimes feel awkward for folks because people are coming to you know, sometimes with the intent of remaining abstinent, but I think having an honest conversation about the realities of relapse and how common it is, and just normalizing that this is part of the process is, you know, including making sure everyone has access to naloxone who is at risk, and then people who were with an history of opioid misuse, recently released from incarceration or other controlled settings like hospitalization, sometimes if they've been tapered off their opioids, or a detox or rehab situation. Next slide, please. So access to naloxone has been widened, particularly in our state. And as of a couple months ago, there's a standing order at Washington state pharmacies. So you no longer need a prescription in Washington state to fill naloxone. I still recommend you prescribe it for patients as a prompt to the pharmacist to give it to them when they go to the pharmacy, and just to avoid any problems with pharmacies that are not aware of the standing order. You can also prescribe in Washington state and many other states third-party prescribing. In other words, if your patient describes to you concerns about their child using opioids, you can prescribe naloxone to your patient to use in the event that their family member has an overdose. There's mandated insurance coverage for all of the Medicaid MCOs and many commercial insurers, and there's liability protection for prescribers and pharmacists, but also a Good Samaritan law for people who call 911. EMS or the police respond to an overdose, no one can be prosecuted for drug possession. And actually, with the Blake decision right now, simple possession is not being prosecuted. But even if that's reversed, it's important for patients to know that they won't be in legal jeopardy by virtue of their drug use if they call 911 if their friend or family member is overdosing. Next slide, please. Washington State, there's a lot of resources out there for training patients on and educating patients on how to use naloxone. And I won't go into details on this. Washington State has kind of updated their guidance to account for, the risk of transmission of COVID in a response. And some harm reduction agencies are giving out these face shields. But essentially, you want to make sure that the patient identifies the overdose, calls 911, initiates the Narcan, and the nasal atomizer is the most common formulation now and the easiest to use. Does rescue breathing if the patient is not breathing or has shallow breathing, and then stay with them until EMS arrives. Next slide, please. Naloxone and fentanyl. Fentanyl overdoses can come on much more quickly and stronger than a typical overdose or a heroin overdose. There's this phenomenon of the wooden chest syndrome, where the chest wall actually becomes more rigid, which can make it harder to perform CPR and can interfere with ventilation. Naloxone can reverse fentanyl overdoses, though it not uncommonly can take more than a single dose. And the recommendation of public health is to proceed as you would with any other overdose, and keep giving Narcan every 2 to 3 minutes in the field until you see a response. And you may need more doses if in fact fentanyl is involved. Next slide, please. So I'm going to speed up a little bit here because I want to get to some of the other material, but you want to make sure your patients have access to Narcan, prescribe it with multiple refills. King County has a new laced and lethal initiative where folks can go online and order anonymous delivery. They just give their address, and they can get anonymous free delivery of naloxone, or they can pick them up at Kelly Ross Pharmacy as part of this new initiative. Next slide, please. So I'm going to move on to safer use counseling. You want to have this discussion with folks who are using opioids or other substances to kind of convey some of these increased risks that we've been talking about. You want to ask permission to discuss what factors might put them at risk. And I think it can be helpful to let folks know some of the stuff we've been talking about that might put them at increased risk. If they've been stocking up on drug supply due to concerns about losing access, if they've had disruptions and so they're not using as regularly and may have lost some tolerance. Methadone, opiate treatment programs are providing a lot more methadone take-homes than they were formerly allowed to do, and that can create a risk if people are over taking their methadone. And then, of course, the major risk of fentanyl in the illicit pill and heroin market. In our region, it's still mainly in these fake, the Perk 30s, these pressed fentanyl pills, but we do see it mixed in heroin as well. And then there's an increased risk using alone if people are trying to adhere to social distancing guidance. So I like the question, how do you protect yourself from overdose, to kind of gauge what a patient's risk awareness is about overdose risk and kind of what they do. If they're, wanting to hear advice from you, advising folks to start low and go slow, to use a tester or a small amount slowly if you have a new supply to gauge potency. If you're using with others, you want to prepare your own drugs if possible, and take turns to prevent simultaneous overdose. On the East Coast, there was a slew of these people who were using together to decrease their risk, but were using at the same time and had simultaneous overdose. You want to have Narcan ready and an immediate way to call for help. Next slide, please. There are some, this is kind of the, there are some resources for folks that are using alone for reasons of social distancing or otherwise. The Never Use Alone website or a number connects you to a volunteer who will literally sit on the phone with you while you use and check in with you periodically and call for help if you don't respond. There's also this mobile app, which is not evidence-based, but pretty interesting. It uses your phone's motion sensor and essentially will notify either a friend or EMS if you're not moving and you don't respond to prompts. So that's kind of interesting. Next slide, please. And then I really recommend these two resources, Getting Off Right and H is for Heroin from the Straight Dope series. They're written by people with medical knowledge and personal experience of drug use, really describing relative risks of different sites of injections, preparing injections, a lot of safety, and not just injection drug use, but a lot of it is describing kind of ways to prepare and administer intravenous drugs more safely. Next slide. And then finally, we're just about out of time. I just want to encourage folks to refer patients who are actively injecting to syringe service programs. If you go to the next slide, we have a list here of the ones in King County, downtown at the Robert Cluess Center, the U District People's Harm Reduction Alliance. In South King County in the north, you kind of have to call to schedule these deliveries. They're not really drop-in sites in the same way. And then there's the Hepatitis Education Project on Jackson. Next slide. And they provide a bunch of services in addition to drug injection equipment, including low barrier buprenorphine treatment, vaccinations, HIV, Hep B and C testing, mental health counseling, and other services. Next slide, please. Syringe service programs are associated with a 50% reduction in HIV and HCV transmission, and that's increased to 2/3 if it's coupled with medications for opioid use disorder. And folks who inject drugs who regularly use syringe service programs are more than 5 times as likely to enter treatment for substance use disorders. Next slide. Jocelyn alluded to this survey, national survey of 173 syringe service programs earlier in the epidemic, and services were disrupted to a large degree. There was a reduction in testing and MOUD services, some site closures, but other changes involve just pre-packing supplies, delivering, providing more injection equipment at a given time. So they were still offering services, and a lot of these have picked back up to more normal function in recent months. Next slide, please. And finally, I'll just close with, fentanyl test strips, which are kind of newly on the horizon, and the Washington Department of Health is kind of excited about their use in distributing them. That there's a big caveat here is that these tests are pretty imperfect. The idea is you take some of your tablet or powder or even tar heroin and dissolve it in some water, and you dip this strip in, and like a pregnancy test, you can detect the presence or absence of fentanyl. I think the major caveat here is the fentanyl isn't always equally distributed in the drug, And so, false negatives are possible, and you can imagine a scenario where someone is falsely reassured by a false negative. So I think you want to couple these, if you do offer these to patients, and they're available at several of the syringe service programs, and Harborview may begin, the OBOT program may begin dispensing these. You really want to couple it with counseling that really, regardless of your result, you want to take some of the precautions we've talked about. So in some ways, it's really more helpful as a tool to have that discussion with patients. But more to come on that, I think, as we get more research. And I'll just close with the final slide, which does look at with the take-home points here that people really are at an increased risk of overdose and other harms due to this convergence of the overdose epidemic and COVID-19 and the societal response. And this individualized, pragmatic, and compassionate approach, which focuses on reducing the risks of substance use, can help keep patients safer and healthier. And specifically really lean into naloxone prescribing, safer use education, which focuses on the risks of unstable drug supply and the risks of using alone. And I think with that, I'm sorry I'm over time here, but I think we can probably make it up a little later. We want to still take a break. So maybe we could just take a couple minute break. I have 9:54. Maybe we could come back in like 3 minutes and move on to our next section. Thanks.
How long do I have? Sorry, about half an hour or?
Ish. 40 minutes.
40 minutes.
We're talking like 10:35, 10:40-ish.
Okay, sounds good. Morning, everybody. I'm Jared Klein. I'm a internist addiction doc at Harborview, and have been tasked with talking about thinking about how we manage pain, either acute or chronic pain, in folks that have opioid use disorders. So we're going to launch right in. So the way I structured the next 30, 40 minutes is thinking about different kind of presentations of either patients with chronic pain who are on medications for opioid use disorder, acute pain in patients who are on medications for opioid use disorder, or pain, acute or chronic pain in folks that aren't currently on MOUD, either actively using or maybe somebody in prolonged recovery, long-term recovery, and how do we approach managing the pain in those kind of complex situations. So hopefully it's helpful. We have some cases, we have some polling questions, I think. So we'll give this a try and see how it goes. Before we start, a couple quick definitions. The first is, what is acute versus chronic pain? And these are arbitrary definitions, but and there's kind of wiggle room, I would say, around these, but generally acute pain is in that 0 to 6 weeks after an injury or some sort of trauma or surgery. There's this middle ground which is called subacute pain, and then chronic pain. Most people think if there's pain that's persistent longer than 12 weeks or so after the inciting injury or trauma, then we would call that chronic pain. And then the other definitions are about pain severity. And again, these aren't clear, but I think it's helpful to think about pain drivers that are kind of in the moderate to severe category versus the mild to moderate category, because you might approach those clinical scenarios a little bit different. So major surgery, broken bones, especially broken, kind of larger broken bones, larger surface area burns, those are more in that moderate to severe pain, versus mild to moderate are often like musculoskeletal injuries or dental issues, headaches, maybe minor burns or minor surgical procedures, things like that. Really, I think that we've obviously moved away from the 0 to 10 pain scale, and really I think want to focus mostly on the function, like what is the person not able to accomplish because of the pain, or alternatively, in what ways is the pain regimen helping the person accomplish whatever they need to do as far as function in order to recover and heal and get better or live their life. So here's the first case. A 52-year-old individual on methadone maintenance, currently 110 milligrams a day, comes into clinic for chronic low back pain. The pain's been present for over 15 years since a work-related injury. They've completed some courses of physical therapy, although not in the last couple of years. Currently, the patient's on permanent disability due to back pain and depression, also has hypertension and chronic hepatitis C. In addition to the methadone, they take sertraline, acetaminophen, and hydrochlorothiazide for hypertension. So the question is, how are you going to, at this point, manage the patient's chronic pain? Would you, ask to split the methadone into 2 equal doses, like a morning and evening dose? Would you start ibuprofen, 600 milligrams, 3 times a day? Would you start oxycodone, 5 milligrams, 4 times a day is needed? Start gabapentin, 300 milligrams, 3 times a day, or send the patient back to physical therapy? So we'll give folks a, and I think as you guys are answering, I will say that there are not necessarily, I designed these intentionally where there aren't a clear right or wrong answer. I think it's more to just kind of guide the discussion. So there might be good or bad aspects of any of these.
Go back to the case.
Yeah, as long as we can do that without having a
Yep, you can go back and the poll will stay up. People are still thinking, so we'll just give them a few more seconds.
So this is not a mix-up question. This is not a board question. This is a let's get us thinking about different things question. All right, so a little bit of a split between splitting the methadone and starting gabapentin with a number of people thinking about PT referral again, which is great. So we'll come back to at the end of this section and kind of talk about different pros and cons. And I see in the chat, there's some nice nice suggestions too, thinking about SNRIs. So great. So, I think I am preaching to the audience here about the fact that chronic pain is really common. And I just wanted to highlight in this study that was done in, I think, the Duke Health System last year that demonstrated that in particular, folks that have substance use disorders generally are more likely than the general population to have chronic pain issues. And in particular, looking at folks with opioid use disorder, they're actually the most likely to have a co-occurring chronic non-cancer pain, CNCP. So it's definitely something that this kind of clinical scenario, you have an opioid use disorder and you have chronic pain, is quite common. I don't think I have to convince you guys about that. The other thing is that there's some data suggesting that people who use drugs might have pain might have more difficulty accessing addiction treatment than those without pain. This was a study last year from British Columbia that showed that basically there's a dose response association. So in the individuals who are using drugs that had more pain, like more self-reported pain in that moderate to severe range, they actually were significantly less likely to have accessed medications for opioid use disorder. And that was true even after they adjusted for potential confounders. There have also been studies, which I didn't show here, the data, but that suggest there's lower retention and increased likelihood of ongoing non-prescribed opioid use in patients with OUD who are having ongoing pain. So it's not only common, but I think a challenging kind of situation. Before you even dive in, I think this is just an important reminder, and in the spirit of QI, I think it's very important to, before you dive into okay, we're going to adjust this about the pain medication or whatever, it's just important to evaluate for underlying causes and just stop and pause for a second. Have we done a thorough evaluation for some new process or some worsening of the underlying process that's causing the pain. So obviously folks, especially if there's, ongoing active use, but even without it, they can have other things happen. They could have compression fractures, they could have underlying, in this patient who has back pain, like could they have some infectious etiology underway? So just stop and, use a judicious exam or a good history, and don't fall into that kind of cognitive bias of just kind of moving right to the treatment plan. The other thing that I'm not going to dwell on a lot is multimodal pain, although we'll talk about it the most in this section. But we always institute multimodal pain treatment strategies, and I put two kind of bins up here: the non-opioid medications on the left, and then the non-medication approaches on the right. And so these are all really helpful tools, and there's increasing evidence that they can really be effective adjuncts. I think it can be challenging to for some folks to convince them that they will get significant relief from these, but I think everyone feels strongly that they should be part of the overall plan. And I think in particular, the non-pharmacologic approaches have a lot of potential. So I wanted to, because the gabapentin was on the list of options on our question, and because we so commonly use it, I think, as internists, I wanted to just spend a minute talking about gabapentin. There have been kind of increasing reports of concerns about gabapentin misuse or kind of use differently than prescribed. And there's some studies that have suggested, like this one from a few years ago in addiction, that suggested that there's actually a higher prevalence of misuse in patients that have OUD certainly compared to the general population. And there's also kind of concerningly, a little more recently, there was a study from Canada, I believe, that suggested that patients who were exposed to recent gabapentin use actually had a higher, and were on opioid prescriptions, actually had a higher risk of overdose, especially at the higher doses. So you can see in this table here that any recent gabapentin use, which was their primary outcome, was associated, even after adjustment, with about a 50% increased odds of overdose, and that it did seem like there was probably a dose response association in that secondary analysis here. They looked at high dose, which is, I think, defined as above 1,800 milligrams a day. That seemed to be a more robust association compared to the lower dose, which I think they defined as less than 900 milligrams a day, something like that. And they compared to the neutral exposure of NSAIDs, which didn't look like there was a significant association. So just something to kind of, I don't know how much this is really changing my practice yet, but I think it's more like on my radar, and probably something that we'll continue learning about more. Yeah, no, I mean, John's pointed out in the chat, like, is it causal or is it a correlation? That's what I think, they tried to adjust for some of those confounders, and it did partially bring it closer to null, but I think it's the verdict is out on that. The other thing I think about is depression, and this is maybe a little bit of a tangent, but it's so common in folks that have OUD and pain, and is probably undertreated. I was shocked by this study from not too long ago that 16% of Americans with mental illness receive over half of all the opioid RX or prescriptions in the US every year. So it's just, kind of wild. And then most studies show that at least 50% of patients with OUD have depression. The rate's probably even higher in folks that have OUD and comorbid chronic pain. So think about it, screen for it, treat it just like you would. We usually use SSRIs, they're safe. This is going to Hillary's point in the chat. There could be a little preference for SNRIs because they do have some evidence of modulating that pain experience by kind of boosting up the serotonin and norepinephrine levels in the brain. So specifically, duloxetine is FDA approved, has lots of FDA approvals for fibromyalgia, chronic low back pain, knee osteoarthritis. But we'll also use other SNRIs like venlafaxine. TCAs, I think we like TCAs for chronic pain and for sleep issues, which are also incredibly common along with the mood issues. You should be a little bit cautious, especially with patients who are on methadone because of the QT prolongation issue. And then of course offer everyone counseling or behavioral health therapy services. And then getting to the crux of the issue, what do you do with the patient's MOUD? I think it can be helpful to adjust the dosing regimen of the MOUD when possible. So both methadone and buprenorphine we think of as having relatively short duration of effect for pain control. And I don't totally understand all the reasons behind that, but we will try to either increase the dose or split the dose of the MOUD when possible. So for patients who are on methadone and have take-home doses, they have that flexibility of splitting their take-home dose, twice a day or even 3 times a day. But when patients are dosed daily at their program, then that they can't come back, and get a second dose later. Generally, that's incredibly burdensome for the patient, mostly, but also for the OTP. So, and then patients on buprenorphine, obviously, you have lots of flexibility about how to dose that. So I think those are things to consider. And then generally, we would say avoid the full opioid agonists. Because of all the risks that we know that come along those. Of course, if there's a palliative situation or really end stage diseases, there's a lot of functional impairment. I think a time limited trial is reasonable if you do that full shared decision making about the risks and do institute close monitoring and monitor what are the functional outputs or endpoints that you're looking at. So, it might come up commonly that someone has terrible knee arthritis and they can't do their daily activities that they need to do, and they're, for whatever set of reasons, maybe medical comorbidities or whatever, they're not a candidate for surgical knee replacement, then you could consider a time-limited trial of full agonists in addition to their MOUD, but you just have to be kind of careful about that. So coming back to this, I think there's different options. I actually, I think that if the patient is able to split the methadone, I think that's reasonable. You guys also thought about starting gabapentin. I think with the caveats that we talked about around gabapentin, that might be an okay thing to do. PT is never the wrong answer. I would probably shy away, like you guys did. I'd shy away from ibuprofen because of his hypertension and the oxycodone because of the risks we talked about with that. So I think you guys are all on the right case or right line of thought there. All right, I'm gonna just kind of move right along if that's okay, but put things in the chat. I'll try to address them as we go. The second case is a 26-year-old individual. So this is the acute pain in somebody on MOUD. So it's a 26-year-old individual on buprenorphine with right maxillary dental pain. The dentist said they need a root canal, which is scheduled for next week. Patient's been stable on buprenorphine for a year and a half, is how lives with partner and kids, kind of doing well in recovery. So how are you going to manage the patient's buprenorphine in this situation? Would you stop the buprenorphine for a few days before the dental procedure? Would you stop it the day before the dental procedure? Would you increase the dose after the procedure to kind of deal with the post-procedure pain? Or would you continue the buprenorphine and add oxycodone on top of it? And again, there's not necessarily there's probably better or worse answers, but there's not a clear one right answer here. And I can go back, I think I can go back to there we go. Not as complex of a case though. All right, great. You guys are already on board, so which is great. Everyone wants to, no one wants to interrupt the bupe, or only maybe one person, which is good. That's a big take home point. So thank you. We can breeze through that. So I want to acknowledge that anytime that there's an acute pain issue, that I think we should just be prepared to think about that as being a potentially risky time for a patient with OUD, whether they're early in their recovery or long in time, in prolonged recovery. I think it's anxiety provoking. I think for anybody that's anxiety provoking. I think it's even more anxiety provoking for folks with OUD because this issue of the fact that they're kind of concerned about their recovery potentially, they're concerned about their adequate pain control. Oftentimes they're kind of anticipating conflict over opioids. And that's both ways, like, for prescribers, we're kind of afraid of being deceived or, having inconsistencies in practice. And sometimes we'll avoid the topic, entirely, which I would argue is not a good strategy. And then on the patient side, they've often have had experiences where they've been maybe mistreated or have the perception they've been mistreated or stigmatized. So I think that is just a recipe for a challenging situation. So clear communication, I think, is really important. You guys already got the points. I'm not going to belabor this, but like whether the patient's on methadone or buprenorphine, either of the agonist medications, we would really recommend continuing those through the episode of acute pain whenever possible. So for methadone, it's easy. We can just combine it with any full agonist. It doesn't really matter which one you choose. You do want to coordinate with the opioid treatment program, especially if you're going to be prescribing for an outpatient hospital. It's kind of easier, but if they're going to be doing urine tests at the opioid treatment program, they won't need to know like, oh, they're getting Vicodin or they're getting oxycodone or whatever. And then for folks on BUP, I think more and more the trend is to continue the BUP through episodes of acute pain, regardless of it's mild to moderate or moderate to severe. There's this theoretical preference for kind of higher affinity opioid agonists because they might be more competitive with buprenorphine at the receptor. I think so. Choosing hydromorphone or fentanyl versus hydrocodone or oxycodone. But honestly, I think that more than that, I think just making sure you take into account tolerance when you're choosing a dose. I think that's probably a bigger issue than selecting one particular opioid. Naltrexone, if you know that there's going to be moderate to severe acute pain requiring full opioids, they really should be discontinued. So elective things should be delayed until that's out of someone's system before proceeding whenever possible. And then, of course, I'm not going to go on this other than to say that oftentimes our anesthesia pain colleagues can be really helpful for complex cases and do either blocks or ketamine infusions or lidocaine infusions or other things that can be really helpful. And then, I think we do want to adequately treat the acute pain, and it's really hard. When I was putting this talk together, I looked for like references as far as how much tolerances are going to be in somebody who's on MOUD or has a history of OUD, and it's really, there isn't good data out there. I think anecdotally, a lot of folks will say like consider a 50% increase above your usual dose. So if you're usually giving somebody, 5 to 10 milligrams of oxycodone every 6 hours, and maybe think about doing 15 milligrams every 6 hours as a starting point. But really, the bigger point is the second point here, that we need to monitor closely to make sure if we overshot or undershot that we can adjust that quickly for folks, which is easier to do in the inpatient setting, obviously, than clinic, but even a quick phone call a day or two later just to make sure that pain is adequately controlled. And then I think for me, the second point about, opioids is a chronic disease, we're not going to worsen someone's OUD if we're giving them opioids, and we're not going to somehow cure or make them better if we're withholding the opioids. I think, and sometimes patients have to be dissuaded about that kind of perspective, and sometimes we do also. And regardless, of course, we're going to institute these same safety measures. We're going to give small quantities, frequent refills, make sure naloxone is available, make sure that we just discuss about how do we secure them, store safely, et cetera. And I should just ask a question about timing. And I don't, so because buprenorphine is it has a long half-life. I haven't noticed any particular pattern in my clinical practice, and I am not aware of any data about, how to time the full agonist relative to the buprenorphine. So I think generally they probably aren't given like exactly the same time, but I don't know that it's going to make a big difference one way or another. So that's a great question though. In the hospital, we don't like intentionally schedule them at different times necessarily. Great. So coming back to this individual, how are you going to manage their buprenorphine? I think option C and D, like you guys said, are both totally reasonable. You know, if the pain is maybe anticipated a little bit less, then you could maybe just increase the dose of buprenorphine post dental procedure and see if that gets the patient through, along with some multimodal things. Or you could continue the bup at the current dose and add oxycodone. Sometimes it comes up about what about decreasing the buprenorphine dose, and I think that's really the same as stopping it. I generally would just continue whatever the outpatient dose is, just to try to not rock that boat, so to speak. Great, how am I doing time-wise? I think we're doing okay. 2 more cases to go. So the next case is acute pain in somebody who's not on MOUD, but is actively using. So a 32-year-old individual admitted with a big deltoid abscess and surrounding cellulitis, started on antibiotics, taken the OR for drainage surgical treatment. The patient has an 11-year history of opioid use, including daily heroin use for the past 6 years, previously on methadone quite a while ago, but left treatment just after 6 months or so. So this is a little bit different question. It's not about pain, it's about withdrawal symptoms. How are you going to manage this patient's withdrawal symptoms in the hospital? Either oxycodone, 10 milligrams Q8, methadone, 10 milligrams 3 times a day, loperamide, ibuprofen, clonidine, or a hydromorphone PCA. And again, none of these are totally right or wrong. It's more about the discussion. The poll's very helpful for me because then I know like, oh, you guys are all over this. All right, so most people, almost everybody wants to do methadone with a smattering of the other things. Great. So I think that the key, I think a lot of this section is kind of talking about is me kind of waxing poetic about things philosophically, but I think that managing patients in the hospital who have OUD and these concurrent acute pain issues is really challenging. I think it can be really rewarding also. But I think that sometimes I have found myself get distracted by either the addiction issue or the pain issue, and that's not always helpful for moving care forward. It's often a distressing part of the hospitalization, or like there can be conflict, and that's kind of stressful. But really, I think that one thing that I like to try to focus on is keeping my attention on treating the acute condition. So the patient came to the hospital, presumably because they wanted their medical issue addressed. And so I think if we as a treatment team and the patient can all keep our focus on that as the primary goal, then we have a better likelihood of being successful and not letting ourselves get too distracted by the other things. I think the other things are important. Like, we're not going to be able to treat that medical issue unless withdrawal is adequately managed, unless pain is adequately addressed. And I think it's an opportunity to start a conversation about substance use treatment, but those things shouldn't be the primary focus. The primary focus is like, we need to get this infection treated. We need to get your wound healed up so you're better. I think methadone is totally a great tool for withdrawal management in the hospital. And you can dose it different ways, starting with 20 milligrams at once. For most patients, that will be fine. You could do more or less depending on, either your concerns or the patient's your kind of anticipated your best guess about their tolerance. No matter what you choose to start with, I think the most important thing is going back and reassessing, and you can give more until those physiologic withdrawal signs start to abate. We do generally say not to exceed 40 milligrams in the first 24 hours, just because it has that long half-life and can start to accumulate if you're titrating a little too quickly. And you can I usually totally leave it up to the patient. They can a lot of patients will prefer to take their dose of methadone all at once in the morning, which is completely fine. You might offer splitting the dose. Some patients find that helpful for acute pain. It's not mandatory by any stretch of the imagination. And I have found situations where we kind of force that on a patient without a conversation, that they don't really appreciate that necessarily. Obviously monitor the QTC, which I'll say I do recommend more closely in the hospitals, because there's a lot of other medications. People are getting Zofran and antibiotics and things. So I think we do keep a little closer eye on that, particularly in patients who have underlying heart disease, of course. And then they're monitored quite closely for sedation and respiratory issues already. And then you can either taper or maintain the dose throughout the hospitalization. If the patient's not planning on going to an opioid treatment program after discharge, then I generally recommend avoiding going up and up and up on the dose throughout the hospitalization, because then that's a big kind of drop off when they discharge. But I have a conversation about, if they're not going to OTP, like, do they want to gradually taper down while they're here, as long as that taper isn't causing symptoms that is interrupting their medical care. I think then I would recommend more strongly that they can maintain the dose. But the key take home is, don't prescribe methadone discharge in these situations. That the DEA will not appreciate that. Buprenorphine is totally fine also for withdrawal in the hospital. We often would start with either 8 milligrams twice a day, or 4 milligrams 4 times a day, like 16 milligrams total. But I have a pretty low threshold to go up on the dose for folks with pain issues. It can be a little tricky if you're giving full agonists, or if they have severe pain, it might kind of not be enough. But in that case, you generally might defer the induction if you have like a pending major surgery. So even if you want to do the induction in the hospital, like if they're planning to go to the OR in the next day or two for a repeat debridement or washout or something, like I would say, well, let's just wait and get that done first, and then we can start the BUP later. And really the decision about methadone versus BUP is really patient preference ultimately, and there's all these kind of logistic issues that go into that. Like, is there an OTP near them? Is there a methadone clinic near where they're located? Do they have access to a BUP provider? Do they have prior experience with one treatment or other that makes them think that one might be better for them than the other? I'm not going to go into the harm reduction things because Jamie already covered that really nicely. There are prescribing limits, and so just to call out for Washington State, for non-operative pain, for non-operative acute pain, we can only give a 7-day supply, and your pharmacist hopefully would help with this. And for operative pain, we're limited to a 14-day supply of opioids and acute pain issues. So they're increasing all these state rules around this. So coming back to this, further withdrawal symptoms, I think methadone is a great option. I would, I think that the PCA is actually a nice option for pain management, but isn't going to be that helpful for withdrawal symptoms probably. So I think combining B and D for the patient's overall kind of opioid plan is a great option. The oxycodone, you can just use short-acting opioids for withdrawal management, but it tends to, first, this dose probably isn't going to be adequate. And second, because it's not as long acting, it tends to lead to some kind of peaks and troughs, which aren't great for managing the withdrawal symptoms. And then I would just encourage you guys, I don't know if they've gotten rid of the heroin withdrawal power plan with the move to EPIC, at least within the Heart Review and UWMC. I would encourage you guys to generally avoid using that because the best strategy for treating opioid withdrawal is generally giving opioids. So these other things are adjuncts, they're okay, but shouldn't be kind of the first line. All right, Jamie, do you think I have time for the last case, or should we skip?
No, I think we're doing good. I think you got about 10 minutes. So.
Great. So the last case is a patient who's in recovery. So 48-year-old individual comes in with right knee pain, and basically the patient has a meniscal tear and the patient seen an orthopedic surgeon who advised repair. Has a history of opioid use, so they have a history of opioid use disorder in prolonged remission. The last use was over 10 years ago. They did take buprenorphine for about 3 years and then gradually tapered off and have been doing well, working, good relationship with children. So no, just in recovery, the substance use disorder isn't kind of in the forefront of their mind, except the fact that they're now potentially needing this surgery and concerned about pain control postoperatively. So what advice would you give about perioperative pain control? The risk of return to use by taking opioids postoperatively is increased. The risk of return to use by taking opioids postoperatively is similar to the general population. Higher doses of opioids might be necessary for adequate pain control given the history of opioid use disorder, or the patient should reconnect with a sponsor or counselor if not already. I can go back to the case if that's helpful. All right, a little bit of a spread. So the most popular option was the risk of return to use postoperatively is increased, but the second most was that it's similar to the general population, and then on down from there. So great. Well, let's, I think we are, it's not too surprising to me that there's a spread because this is a pretty, we're entering an evidence-free zone primarily. So I think there is a lot of uncertainty, but let's kind of talk about it and hopefully a little bit of discussion about this. So yeah, there it is, limited data for patients in prolonged recovery. I think we just don't know that much about the risks or the best management strategies in these situations. Cody said he would have chosen I don't know, which that's why I didn't include that option because then everyone would have selected that. So I think mostly based on anecdotes and some published case reports that there, a lot of folks feel like there is probably an increased risk of return to use in this type of situation. And I think it's plausible given the stress and anxiety and this prior opioid exposure. There are long-lasting changes to the opioid system in the brain after kind of extensive opioid exposure. How long-lasting those are, I think, is not totally understood. For this individual, there are a lot of protective factors, so that's why I think that second option is totally reasonable too. I mean, the person's been in recovery for quite a long time at this point. We didn't have information about engagement, but it's felt that folks that are more engaged in recovery support structures are probably better off. Those folks that have more stable kind of home and work environments, and if they have co-occurring mental health issues, if those are well treated, those are probably protective factors. So the individual in our case had at least the items 1 and 3 here, so as far as the protective factors. I think that the expert opinion that isn't exactly based on rigorous evidence is that you want to really have clear, open, and kind of proactive rather than reactive communication about the risks of opioid exposure in these situations. And thinking and just remembering that the patient is different than the folks who we had in earlier cases because they don't have that physical dependence or tolerance that comes along with it because of that prolonged period off of opioids. So a reasonable plan would be to, of course, as always, maximize the multimodal analgesic plan. Enhance the recovery supports if available. Like, could the person, reconnect with a sponsor and let that person know that they're have a surgery coming up and might need extra support. I think this is, if possible, if the person was in the past, snorting oxycodone or smoking oxycodone, like probably avoiding oxycodone seems like a reasonable plan if possible. But how much impact that's going to have, I think, is a little bit hard to say. And then I think I have done this in the past, like, consider preemptively restarting the MOUD. And I think in this case, it would be totally reasonable to offer a resumption of buprenorphine, potentially pre-procedure or certainly post-procedure as kind of part of the post-op pain management plan. Sometimes patients might be reluctant about that because they kind of have wanted to move beyond that. But I think it's the whole conversation about it's not a crutch. This is a treatment and it worked well for you before, and let's use it for a time limited, you have this acute stressor, let's use that for this period of time. And then you've been successful before, so you can be successful again. So I thought I saw maybe a comment here. Yeah, are there factors related to how we previously used it might increase or decrease the use? Injection versus oral use or others? Not to my knowledge. I'm not aware of any. I think if I'm understanding the question correctly, John, you're asking like, if he was previously injecting, would he be at higher risk of going back to use post-operatively? And I don't think that we clearly know the answer to that. And I wouldn't assume that there's a reason that prior route would put somebody at risk, as an example route. But so I would probably lean towards A, like you guys did, and I would not choose C because that physiologic tolerance should be gone at this point. But A, I think A is reasonable. D is reasonable potentially, and C is. I think C is. It's a little bit hard to say. He probably is at lower risk than other patients. But great. Well, that's all for my part. And there's maybe a minute or two for questions, either for my section or for Jamie or Jocelyn.
Right. Well, if questions come up, please please keep them coming. I think we have we're right on time. Thanks, Jared, for getting us back on track. I think we can take a 5-minute break, stretch your legs, and we'll reconvene at 10:45, and we'll be with our small group facilitators. So I'll introduce them, and then we can kind of break up into small groups. So see you guys in a few minutes. Everyone. So I think if Javel, if you can do your magic to break us all up, we're going to break up for most of the rest of the session and to small groups to discuss some cases that are in the chat there. I know people in their continuity clinic, these are mostly outpatient management cases about buprenorphine. I know people come at this from different experience, and some clinics have a lot of built-in support for buprenorphine prescribing, others not so much, or folks are referred out. So just a chance to learn from each other and from the facilitators, primarily around kind of communication strategies to engage and retain people in care. So and then at the last few minutes, we'll kind of give a warning and then pull everyone out again to the big group, and hopefully we can kind of just close by sharing out a few things that have come up that we learned, or some takeaways from the small groups. So I guess let's let's do it.
Perfect.
So Lauren threw the document in the chat. Threw it in there. Oh, you sent it just to me, Lauren. We're going to send that in the chat again. So you want to click on that before you go into your breakouts.
Okay. Oh, I see it here.
Okay. And away you will go.
Okay. Wow. We got sucked back in. Was anyone else mid-sentence? Well, great.
No, well, sorry, my group only got through we barely got ourselves through the first case, so I'm sorry.
Same with our group. Did anyone make it to the second case?
No.
Okay.
No.
Okay, well, I guess that means there's a lot of fertile material to discuss in the first case. Well, just hoping we just have a few minutes. I was hoping people might be willing to share something that they took away from the small group session that they're going to take with them into practice, or something they found interesting, or a take-home point that you guys discussed. So please just speak up, or write comments in the chat if you're more comfortable doing that.
I think something that was helpful was Bryce was telling us different situations and different kinds of use with short versus long acting, specifically like with fentanyl patches and methadone.
And street fentanyl use as well.
We talked a little bit about in the first case when the patient relapsed, like reframing it as, we had this very positive response to treatment during the time frame rather than a failure. And I think, kind of really just trying to reframe things as looking at like the successes of treatment rather than the bumps in the road.
Great, thanks, Cody. I like that. Yeah, really taking a strength-based approach and trying to empower somebody instead of kind of feeling bad about the last couple of weeks. Anybody else?
One thing I'm going to take away is we talked about the importance of counseling patients on that typically we would use things like buprenorphine for at least 6 to 12 months. And then when somebody is expressing a desire to taper off, kind of exploring that, like, is that fully an internal thing? Are they getting like influence from, are there other folks saying that they should, go off of buprenorphine for whatever type of reason, and really try to explore that and figure out what's going on?
Great, thanks, Sarah. Yeah, what's underlying this desire that could significantly increase someone's risk?
It is a good discussion in our group about how to navigate and present conversations about urine drug screens as part of buprenorphine induction, and how to explain the rationale for that, and increase buy-in from the patient about destigmatizing the use of a urine drug screen and that it's more for therapeutic monitoring.
Okay. Well, thank you guys so much. Thanks for our facilitators and thanks to everybody else. If there are other questions that come up or comments or you guys have suggestions, we're hoping to do a kind of an addiction theme half day, every year, and we might kind of rotate the the substance or some topics. And so if you guys have, let us email us with any feedback or you put in your evaluations and also any other things that you're encountering that you'd like to kind of have more attention paid to in this realm. Let us know so we can kind of try to get you guys the information that's most helpful. Okay. Well, thanks so much, everybody. Lauren, any announcements or anything, or can they just?
No, thanks everyone for coming, and thank you all for participating today and for a great morning.
Thanks.
Everyone's good to go.
Jamie, can you stick on for a minute?
Oh, sure.
Just an observation. I think that I was saying this because I hopped